abnormalities using genetics, chromosomal microarray, and exome sequencing. Coming to the background, genetic abnormalities associated with agenesis of DV is hypothesized to be underdiagnosed using conventional cytogenetic studies alone. In the recent years, advancements in genetic testing, chromosomal microarray, and exome sequencing have allowed for comprehensive analysis of fetal genome, enhancing the diagnosis of genetic abnormalities.
Narmada, your slide is not moving and it's not in full screen mode also.
Now, ma'am. Is it moving now, ma'am? Changing?
Yeah, it's changing, but slide share mode.
Not in full screen mode, Narmada.
Stop sharing, make it into full screen, and then share it again. It will work.
Okay, sir. Saranya, ma'am, is it full screen now?
Narmada, slideshow. Put slideshow.
Press.
அம்சரிக்கா கண்ணா பிபிடி அம்சரிக்கா
சென்ட் பண்றேன் சார்.
இங்கேயும் ஷேர் பண்றோம். Alternatively, hold on, don't do anything. Hold on. In your click on the slide once.
Yeah.
Click on the slide, main slide. Click. Now press the down arrow. Keyboard la.
Yes, sir.
Panniya?
Yes, sir.
La right side arrow. Avlala. Okay, there's some issue with your PPT version maybe. It looks very outdated version. All right, send the slide. We'll share it from here.
Kunyo. Come. Kunyo. Kunyo.
Send it to the email, ma. So in the meanwhile, let me ask all of you, how many of you, as a protocol, document ductus venosus in the target scan? You can open the mic and let's discuss.
Sir, I usually do for the past 3 years. I'm doing because I have missed one case of DV agenesis where the NTA I have not done, and it has been suboptimally documented in the scan.
Yeah, very good. Yeah, Harshini says yes. Siddesh looks but doesn't document. All right. Now, when you say you will document Amuda, which is the section that you prefer?
I'll do axial section and then I document the waveform. If I'm in doubt, I'll do a sagittal section. Yes, sir.
And do you have any specific color setting? $8.15.
No, sir. Not specific.
Okay, so what about our people? What is the specific color setting that optimizes the ductus venosus?
Sagittal view, PRF of 1.8 with acoustic output of around 60.
Very good. So the PRF that brings about DV best is the one that is low enough to pick up the umbilical vein flow and is low enough to showcase the aliasing at the origin of the ductus. So ductus we discussed extensively in that case of the week, no? The duct is directly in alignment with the umbilical vein. If you see the portal sinus will receive the umbilical vein in its anterior curve, and then it takes a swing towards the right side. But at the apex of that swing, it will give off the ductus posterior superiorly. Okay. Antero inferiorly, it will receive the umbilical vein. So, and then it will go like that. Okay. Therefore, the duct is at a high velocity always. You have to demonstrate that bit. Okay. So, Amuda, when you say you document it axially, would you be able to pick up? Of course, ADV you will be pick up the total agenesis, but what about the abnormal location, the abnormal position of the shunt? Rashmi has told she sees at NT and recently at 20 weeks also.
So yes, the second trimester you are asking.
Oh,
right?
Second trimester. On the axial, when you see it in axial, would you be able to pick up the shunt displacement also? The so-called DVSS?
If I have any doubt in the direction, what is the course of the normal DV, then I'll look into the other sections.
Yeah, so that is the question. So when you do it in axial, how do you get the entire ductus venosus in position? I'm just Can you see the screen? Narmada, can you see the screen? Are we cut off from the rest of them?
Screen is good, sir.
Thank you. Narmada, start.
Sir.
So before you start, let me complete that question to Amuda. So as you start doing in axial plane, okay, to get the DV, you have to do a bad AC plane. Okay, so the good AC plane, the umbilical vein touching the abdominal wall should not be there. No, so when you do a bad AC plane, the ones that I reject, in those, if you put color, you will start seeing. So you have to tilt the angle. It should be an oblique axial, the one that shows the umbilical vein from the insertion close to the abdominal wall onwards. If you see, then it will show the C curve and the initial portion of the duct. You'll be able to show. Okay. If there is any change in that over time, you will know that the shunts usually will be to one side. It won't be from the apex of the C curve in axial plane. Understood? And also, you will see the full duct in the axial plane itself, through axial plane. Okay. You need not have an oblique axial plane. Suddenly in AC itself, you will get. So all those things are close. Yes, Narmada, start.
Yes, sir.
Thank you.
I'll start from the aim of the study, sir.
Okay.
Aim of the study is to investigate the association of agenesis of ductus venosus with genetic abnormalities using genetic studies, chromosomal microarray, and exome sequencing. Coming to the background, genetic abnormalities associated with the agenesis of ductus venosus is hypothesized to be underdiagnosed using conventional studies alone. In the recent years, advancement in genetic testing, likely CMA and exome sequencing, have allowed for comprehensive analysis of fetal genome, enhancing the prenatal diagnosis of genetic abnormalities associated with ADV. Despite the potential of genetic techniques in the research of ADV, there is a paucity of genetic studies addressing the ADV cases in the literature. For example, Maudab et al. Published a systematic review of literature in the year 2015 describing 259 fetuses with ADV, of which 154 cases were done genetic testing. Conventional karyotyping was done in that cases, in which 38 fetuses were diagnosed with chromosomal abnormality. In the year 2017, Pecco et al. Have done a largest literature of review from the publication spanning 25 years.
These are all outside the slides, is it? I can't
Yes,
find.
sir. Yes,
Okay.
sir. Yes, sir. Yes, sir.
Hmm.
In this study, they have included 410 fetuses, of which conventional karyotype was performed in 141 cases, and 48 cases were diagnosed to be abnormal. However, none of these studies included either CMA or exome sequencing genetic evaluation. Next slide, sir.
அதான் next slide தான் இருக்கும்.
Okay, sir. In this study by McBride et al., prenatal features associated comorbidities and clinical course of agenesis of ductus venosus in the current era have included chromosomal microarray and exome sequencing genetic evaluation. In this case series, 14 cases were studied and genetic testing was done in 8 cases, of which 6 cases were diagnosed with chromosomal aberration. In this study, however, only 1 case underwent exome sequencing.
Okay, so this is introduction. Okay, when you write a paper, in the introduction, you have to say what is known so far in the literature about the topic that you are going to say. And then you have to say what is the lacunae in the existing knowledge. So that is introduction, how you write introduction. When you write a manuscript. What is known so far? So a brief recollection of not the entire literature review, but a brief and pertinent recollection to substantiate what is known in the field. Then you have to point out what is the lacunae. Okay. Then you have to say, how do you aim to fill in the lacunae? Remember, most of the research is yet another brick on the wall. There will be a wall that is being built up slowly. It's built globally. Each one of us will place one more brick. If it's a suitable brick, it stays. Okay, right. So what she has done is she has told what is known so far and what is the lacunae. Lacunae seems to be lack of information beyond KT. Okay, yeah. Yeah.
Next slide, sir.
Next slide.
In this study, they have aimed to investigate genetic abnormalities associated with ADV with the integration of chromosomal microarray and exome sequencing into clinical practice. Next slide. Coming to materials and methods, it is a retrospective cohort study. It was done between 2013 and December 2022. Inclusion criteria, availability of first and second trimester ultrasound scan results. All pregnancies who attended a routine screening were considered eligible, and who were diagnosed with ADV were included in the study. Exclusion criteria, pregnancies without follow-up or those with incomplete files were excluded.
So do they mean to imply that from 2013 they had done CMA and exome, or is that they have just stored the DNA and they are using it now?
But they didn't mention about DNA storage and the studies, sir, in the study.
Yeah, okay.
Coming to data collection, medical records were extracted from the hospital computerized database. Evaluation of DV is performed in all women as part of routine anatomical screening. When ADV was diagnosed, full anatomical survey with detailed echocardiogram was performed. All were referred to genetic consultation, and genetic studies were recommended in all cases, including conventional karyotype, CMA, and exome sequencing. Data on gestational age at ADV diagnosis, obstetrical complications, associated abnormal ultrasound findings or genetic findings, pregnancy outcomes, as well as complications, namely termination of pregnancy, spontaneous abortion, stillbirth, preterm delivery, and mode of delivery were extracted.
All right. Where was this study conducted?
So they have mentioned that it was done in a tertiary center.
Where? Which continent? Which nation? Any idea? Affiliations.
Rabin Medical Center, Israel.
Israel. Okay. Yeah.
Coming to statistical analysis, it was performed using SAS software version 34. Descriptive statistics are presented by number and percentage for categorical variables and mean and standard deviation for continuous variables. This was approved by local institutional review board. Informed consent was waived due to retrospective design of the study.
Yeah, nothing much to discuss on statistics because this is proportions and this is our means. Okay, this is only we have been dealing day in and day out in all journal clubs, which sort of tells us that in most of the prenatal literature, complex statistics is not required. Okay, because our field is still evolving. We are not going to be in RCTs for the next 5-6 years, maybe, or even more. We are just building up our databases. Okay, check. Oh.
Coming to results, ADV was diagnosed in 33 fetuses, and this table shows baseline characteristics. Mean gestational age at ADV diagnosis was 21 weeks plus or minus 8 days. It ranges between 12 weeks to 38 weeks of gestational age.
Okay. To all of you who are thinking of writing a paper, okay. Once you decide the protocol, what data you have to collect, and you are collecting, before you sit and analyze the data, you must make ghost tables of your results. Typically, 3 tables you have to make minimum. Okay. One is the baseline characteristics. So that is the example here. See, clinical and epidemiological characteristics is the modified way of saying baseline characteristics, where you will tell about the population. Okay. That information is required for anybody else to know if population is comparable. That means if your results would mean anything to me at all. Okay. Suppose it is all women are 19 years old, or all are very old, 38, and you are dealing with a young population. If they have a totally different ethnicity and the disease in question has ethnicity as a factor influence, all those things are important. So when you write the ghost table, you list out all that are required on the left side. So the variable like this, what you want the variable to be expressed. Okay, let me. Okay, so years, that is the unit. Then how you are going to express mean and standard deviation. So that comes here. Understood? So here, ideally you should have written n, percentage. Okay. So that means this is shown in proportion, this is in mean standard deviation, and the unit is in weeks. Suppose you want to express even age as a category, you can say split it into, let's say, 18 to 25 or whatever that makes sense in that particular situation. Okay, understood or not? So you may want to know whether people in the so-called AMA category, how many were there? Suppose you want to know that fact, or you want to present that fact because it's important in that particular. So you may split it into 35 and above, 25 to 35, and less than 25. That's also okay. So in that ghost table, you should construct first. Before you touch your Excel, you should do the ghost table. Got it or not? And the ghost table is constructed like this. Then we can proceed. Yes. Hold on. Let's go here. Anything important that can interfere with our interpretation of ADV? This one, okay, ART, about 15%. Okay, all right.
Out of these 33 fetuses, 8 cases were isolated DV and 25 cases were diagnosed with other ultrasound findings, abnormal ultrasound findings. This table shows abnormal ultrasound findings associated with agenesis of DV in 25 cases. General findings includes increased NT of more than 3 mm in 6 cases, and fetal growth restriction was seen in 9 cases. Vascular findings like portosystemic shunt was seen in 4 cases, a single umbilical artery in 6 cases. Totally, 15 cases shows cardiac anomalies, of which ventricular septal defect being the most common malformation seen in this category. It was diagnosed in 5 cases. Other serious malformations were pleural pericardial effusion, atrioventricular canal, cardiomegaly.
aortic coarctation and double aortic arch. That was blocking her view. All right. So look at this. SUA, shunt, PR, UV, all were present in that particular case. Oh, okay, this was not there. So these two were there. So Adi used to say, if you have one vascular, go and search for all other vascular. Okay, it's a very common association. Cardiovascular, this one may not be considered under cardiovascular. Okay, so this should come out. This should in fact go along with this lymphatic. In fact, it may not be even lymphatic. If it's a ADV with a UVSS, then there's a volume overload and there may be markers of hydrops. So the effusions you don't bring under the defects, okay? So, or malformations. And even this one is questionable. But if you see ADV, of course, echo, a thorough cardiac evaluation is indicated because of these associations. Okay. And we know that ADV ductus itself is a component of trisomy, aneuploidy evaluation. So this, and this is important. Okay. Why? Clinically, it's more important than just being an association. So, if there is a placenta-based IUGR and progressing, the best tool to surveil early FGR is not there, isn't it? So, in a way, it is important to know. Okay. All right. So remember all these things so that we can think of those things. Yeah.
They were associated CNS and skeletal malformations. CNS malformations included microcephaly, ventriculomegaly, dolichocephaly, small corpus callosum, holoprosencephaly, and Birman agenesis. Skeletal anomalies were absent humerus or unfemur, clubfoot, absent nasal bone, arthrogryposis, kyphoscoliosis, rocker bottom feet.
All right. So in all these things, it becomes a additional finding, nothing much connected.
Genitourinary malformation associated were pilotasis, renal agenesis, small scrotum micropenis, and there were cystic hydroma, asplenia, esophageal atresia, in which there was a polyhydramnios, omphalocele were associated. There were 7 cases which came under one system involvement, and in 6 cases, there were 2 system involvement, and in 12 cases, there were more than 2 systems involved.
What would have they classified the ADV into subcategories?
No, sir, they didn't mention.
So, yeah. So what would have been more interesting is it a case of ADV, the simple agenesis of the ductus venosus, or is it a shunt variety, or is it a total, what is that? No DV at all, and the umbilical vein joins the systemic circulation? Because I feel the different categories would have different associations, okay, from what we have seen, right?
Coming to genetic studies of agenesis of DV, out of 33 cases, 22 cases underwent genetic testing. In isolated category, out of 8 cases, 6 cases underwent prenatal invasive testing, of which CMA was done in all the 6 cases, and it returned to be normal in all the 6 cases. 1 case underwent additional testing, exome sequencing, that also returned to be normal. In 25 cases of non-isolated DV, 16 underwent invasive testing, out of which 1 underwent karyotyping and trisomy 21 was diagnosed. 15 cases underwent CMA and 2 returned to be abnormal. The 2 cases that diagnosed were Prader-Willi and Angelman syndrome, 16q24.3 microdeletion syndrome.
15.
16q24.3 microdeletion, sir.
Oh, okay. அது இல்லாம.
Yes, sir.
So one was 15q region and the other was 16q region.
Yes, sir.
So it can't be both Prader-Willi and Angelman. So, okay. So in CMA, that 15q region, that is that critical region for Prader-Willi and Angelman, that was deleted heterozygously, isn't it?
Yes, sir.
And the other one was 16q microdeletion. Okay.
Of the 13 fetus with associated ADV under normal CMA, 4 underwent exome sequencing, in which 3 were diagnosed with chromosomal aberration.
என்ன வந்துச்சு?
Sir, 2 known symptoms.
Chromosomal aberration இருக்காது. Point CNVs இல்ல SNVs ஆகும்.
Yes, sir. Sorry, sir. Genetic aberration. 2 cases of Noonan syndrome, sir, with RIT1 gene mutation and BRAF pathogenic variant. Other one was LP variant in CASC gene, sir, X-linked intellectual disability. With the spontaneous cerebellar hypoplasia. It was there in next slide, sir.
Oh, okay. So of the 25, so this would have been excluded. These 3 would have been excluded. So I'm just thinking, if you go stepwise, then we would still have to offer 23 women to find out these 3 cases. Okay. So
totally 6 out of 22 cases, genetically analyzed cases in the study were diagnosed with genetic aberrations, sir.
Yeah, 6, of which 3 were molecular diagnosis, isn't it? That is single gene disorders. 2 were microdeletions, and only 1 was a proper chromosomal number abnormality. Okay.
And this is the table showing genetic abnormalities associated with non-isolated agenesis of DV.
So there was one microdeletion in 15q, that's what we said, and then another one 16q. So these 2 would have been picked up by CMA. Then RIT1, BRAF, CASC. CASC is spontaneous cerebellar hypoplasia. BRAF is Noonan, RIT1 is Noonan. And this is Down syndrome. Paternal. See this? Inheritance is paternal, it seems. So the father also had a Noonan syndrome. Say. Yeah, okay. Oh, I have to proceed.
Coming to pregnancy outcome, 18 live births were recorded, 6 cases of isolated ADV, and 12 cases with associated abnormal ultrasound findings, in which termination of pregnancy was more in non-isolated cases. There were 8 cases of termination of pregnancy.
Yeah.
And there was 1 stillbirth in non-isolated category.
So to go back, they didn't find any Turner syndrome, no?
Yes, sir.
You have our data, no? To present
Yes,
at the end? Yeah.
Yes, sir.
So generally, large NT, okay, with some other lymphatic, say pleural, distended jugular lymph sac, or a little bit of pericardial, and a DV abnormality. Okay. Turns out that this combination mostly favors a Turner syndrome, and if not, turns out to be a Noonan syndrome. So remember these two. Okay. So anyway, for large NT with DV, without DV, you would do a CMA, you will pick up the Turner, all right. But when this combination is there with a DV abnormality and a little bit of pleural, little bit of lymphatic somewhere, okay, the NT itself you can take it as lymphatic only. Think of Noonan. Okay, so that's being validated here, but only thing is I'm surprised that they didn't get a Turner syndrome. So,
Sir, I'll present our clinical data in the end, sir, or I will do it now.
say that again.
Shall I present our clinical data now, sir, or I'll do it in the end?
Yeah, now you can present.
It is in the end, sir, slides.
எங்க இருக்கு எண்ட இதுவா
Okay, sir. In our center, we have done a retrospective study between 2008. Data were collected between 2018 and 2024. We have studied 112 fetuses that diagnosed with DV anomalies. We have categorized into three categories: simple agenesis of DV, ductus venosus systemic shunt, umbilical vein systemic shunt. There were 57 cases of simple agenesis of DV, 45 cases of ductus venosus systemic shunt, and 10 cases of umbilical vein systemic shunt. Next slide, sir. We have offered genetic testing in all cases, out of which only 34 cases underwent prenatal invasive testing, and 11 cases were diagnosed with abnormality. In simple agenesis of category, there were 5 abnormal cases, and all the 5 were Turner syndrome. In DVSS category, there were 4 cases of
abnormal outcome, of which all were.
So there were 6 cases of abnormal outcome, of which 4 were Down syndrome, 1 was monosomy 16, and 1 was trisomy 16, sir.
Oh. Okay. So this trisomy 16, what gestation do you remember?
Sir, I think it is 22, 21.
And maybe I think it may be either partial or mosaic. No, most likely it should be a partial or a mosaic. We'll get into that genetic details then. You may have to explain that.
Okay, sir.
When you write it up. So here what we are seeing is this big data is not being reflected in their series. Okay. Okay. So there's something new we can tell the world. Yes.
There was no chromosomal abnormality seen in DVSS.
இது என்ன புது ஸ்லைடு இதுல வந்து 4 அந்த டினாமினேட்டர் மாறுது.
சார் இல்ல சார் அது வந்துட்டு டவுன் சிண்ட்ரோம் மட்டும் 4 கேசஸ் சார். இது டோட்டல் ஆஃப் 6 கேசஸ் இன் which
டினாமினேட்டர் மாறுதுன்னு கேக்குறேன். இது அப்டேட்டட் டேபிள்.
No sir, genetic testing la 34 cases only underwent genetic testing sir. That is
Okay. So this is overall group.
Yes sir.
Okay. So if you want to say like that, do you have data regarding the outcome of those who didn't undergo genetic testing and continued?
No, sir.
So
I'll,
you have to find out, okay?
yes, sir.
They didn't, we offer, they don't take it, and then ultimately the baby is born. So you need to at least have a picture of the baby.
Yes, sir.
Applicator they won't send, but yeah, okay. What happened to the UVSS? None of them took the genetic testing?
No, sir. It was associated with cardiac abnormality and multiple other findings, sir. So they have underwent termination of pregnancy.
Yeah. So that is something our what we observe in our patient population. The genetic testing they will do that. If it turns out to be normal, I could still have the baby, then I would do. If anyway it's a gone scenario, then I wouldn't do the genetic testing. Okay.
This is what we concluded, that simple agenesis or abnormal shunt categories are associated with the genetic abnormalities, and hence genetic testing is indicated in all cases. Direct connection between umbilical vein and systemic circulation, that is UVSS category, is associated with high degree of cardiac compromise and mortality. In all categories, associated defects in cardiovascular system and non-cardiovascular system are presenting, indicating an extensive evaluation of fetal anatomy.
In all categories, associations are present, but not in all cases. Okay.
Yes, sir.
Yeah. Now go back to the study's clinical implication.
Yes, sir. Clinical implication of this study is isolated ADV in this study was not detected with genetic aberration, whereas ADV with abnormal sonographic findings showed 37.5% incidence of genetic condition with various phenotypes.
So that is something that is not in line with what we have found, isn't it? So it's an important thing. It gives us the basis to tell our data also. Always, if there is a discrepancy of what we are seeing in practice and what is being published in the literature, then it provides grounds for you to tell that this is what is being shown in the literature, but this is what we are observing. Add this to the literature.
Genetic abnormalities in the cases of ADV cannot be detected using CMA or conventional karyotype alone, emphasizing the diagnostic yield of exome sequencing. Agenesis of DV associated with abnormal ultrasound findings is commonly correlated with genetic abnormalities and unfavorable pregnancy outcomes. Genetic testing, chiefly among ADV cases associated with abnormal ultrasound findings, enable early diagnosis of fetal pathologies associated with ADV and providing better parental counseling. Coming to limitation, the sample size is small, particularly those cases tested by exome sequencing. Some patients chose not to undergo genetic testing despite the high risk of chromosomal or monogenic disorder due to multiple structural findings. This could lead to probable estimation of genetic conditions. Further studies with a large number of participants are needed to confirm the results.
Yes.
So what is already known in this topic is agenesis of DV is a rare congenital anomaly with a variable prevalence of 0.04% to 0.6%. ADV is known to be associated with an increased risk of genetic abnormalities, fetal malformation, and adverse perinatal outcomes, including fetal growth restriction and stillbirth. Chromosomal abnormalities detected by conventional karyotyping occur in around 17 to 42% of cases of ADV. However, other genetic disorders will not be detected by conventional karyotyping alone. Next. This study added the information that using genetic testing, chromosomal microarray and exome sequencing enables the identification of genetic syndrome not listed in the literature as associated with ADV and which would not be detected by conventional karyotyping alone. Exome sequencing offers unparalleled resolution in identifying genetic variations associated with ADV, which cannot be detected using CMA alone, emphasizing the importance of genetic studies and enhancing the diagnostic aid.
Unparalleled resolution கொஞ்சம் அதிகமா தான் இருக்கு. It's okay. All right. So, what is the take-home message? Look for DV. If you're already looking for DV, okay. Otherwise, think of adding it. When you have an ADV, extensive surveillance of the fetus, from the case of the week, everything, and offer invasive. Okay. It's a strong genetic marker. No? Quite strong. So we have to offer. Then the question comes, what to offer? To what extent should we go for a genetic evaluation? Even we can't draw inference from our own numbers because we have not offered exome sequencing, whole exome sequencing. But from the data between that and ours, that 16 microdeletion is there. 15 also seems to be there. Okay. So it's a good idea to go for CMA. Okay. So usually our QFPCR, if aneuploidy KT, if not CMA. And as usual, it is associated with Noonan. So think Noonan and explain the limitations of WES and maybe offer. Okay. Or we can wait for some more information on ES and then we can start offering routinely. But at this stage, think of WES also. Okay. Adi, what are your comments?
Mani,
Yes.
sorry, I missed this lot of the talk. What is the question?
What is your protocol when you see a absent DV as far as genetic testing is concerned?
Okay. Right now, for almost everything, we are doing exome first. That is the exome sequencing plus copy number variations, clinically relevant ones. So we are doing that for almost everybody now. Because
hold on, let me explain to them. That means it's a test that will tell you what the CMA tells and what the WES tells. Okay, so yeah, okay.
The main reason is because if you wait for a CMA and you still have to do whole exome sequencing, many patients will get fed up by the time you say there is one more test.
Yeah.
And again, when you do an exome sequencing, if there is a Vivo US, and then we say we do the parents also. So it's a nightmare to counsel any of them.
Yes.
So do both. Sorry?
Yeah, so do both from the beginning instead of.
Yeah, that's what exam first will be a nice compromise rather than waiting for every single step. In ideal academic world, you can do only the karyotype first, then microarray, and then you can extend to whole exome. So gradually we giving up on karyotype and straight away doing it CMA, and then CMA is a minimum, and then whole exome later. If you don't have any cost constraints, you do both CMA and exome sequencing straight away.
Okay, thank you.
And I wanted to ask you, there is one, your classification is simple ADV, no?
Yeah.
So that means you're not looking at portal system and making a decision.
The portal system is looked at. Nothing else other than the absence of ADV. Rest all appears normal. Then that is the...
Correct. So this was not included in the Acuron's classification, no?
Yeah. So I asked him in the FMF conference one, and he shot back with the most hostile return question. So he said, I asked, so what was the DV in all your cases? How was the DV? I think he got offended with that and he said, do you know what is DV? He said, oh, yeah. What is DV? Tell me. Then the moderator
My
was
God.
Ravi Choi, so he came into the rescue. He said, "No, the
Rescue.
question is the DV was abnormal or something like that." He said, and he sort of doused
Yeah, yeah.
out the situation. Yeah, so
So
I don't know why it was not included. Probably his focus was on the shunts.
no. What I'm thinking physiologically, if the
Yeah,
DV is absent, you might develop shunts because of the excessive blood flow. All
not
the blood
always.
goes to
No,
liver.
the SADV is quite common, and we also map the portal venous system. Nothing happens.
Yeah. I mean, several times I've seen simple agents of ductus venosus, but there are no shunts.
Yeah,
But shunt identification can be extremely difficult.
yeah,
So finally, I make them as if I have to classify according to Acheron, I would make them as 3A. And anyway, we do investigation.
yeah, yeah.
So and if there are shunts, some of them will close. Many of them may not be symptomatic, and if they're symptomatic, they can ablate it.
Yeah. So what
So
we follow is if we see it, then we will classify it. Otherwise, we will keep it as SADV only.
yeah. So what do you
Yeah.
do? What's
Yeah.
your protocol in investigation?
Ours is Q of PCR, CMA. And if we have anything else, then we offer WES. Most often they don't take it. The
Yeah,
cost
most
is
often they
very,
don't take it. They terminate.
the cost is very prohibitive.
Yeah. So you have about 110 cases.
Yeah.
Yeah, I think it's a high time that we all sit together and composite present publication we should do. I have more than 100. Bijoy has got 100, nearly 100, and Vivek also has got it. So totally 500 cases it will become.
Yeah.
I keep telling one of my fellows, they initiate and then stop it.
Suchitra and Narmada are into it. Maybe they can send the Excel. If you can ask your fellows to fill those numbers,
Yeah.
then we can sort of publish it.
Because
But
none
I
of
have
them.
already given them deadlines, so ask them to send it fast.
All right, good. Done.
Done.
Okay.
Let's get to the questions then.
And also,
Please.
what's your since when you started looking at ductus venosus in a anomaly scan?
Yeah, around 2018.
18. Okay, roughly. Yeah, that was 16 was his Acheron's.
Okay.
I started looking at 16 onwards only. Before that, I don't know how many we have missed.
Correct.
Okay, thank you.
Thank you, Adi. So, axial view. Okay, Rashmi has told what is her protocol. And Amuda, what is the ideal setting? I have told you it's PRF should be 1.8 and decrease the gain, color gain or the acoustic output such that there is no bleeding. It is restricted within the lumen of the umbilical vein. So keep the umbilical vein as your guide. In your study, simple ADV 6 Turners and DVSS 4 T21, was there any other finding? So I will ask her to tabulate that and present Satya. I can recollect from the T21 group that one was referred as intermediate risk in the first trimester. The other one was referred for persistent extension of the knee joint. So we made a diagnosis of congenital dislocation of the knee, genu recurvatum. But because there was DVSS, we put the needle. Otherwise, we were like telling them, okay, nothing to worry, this can be tackled postnatally around 17 weeks. Simple agenesis, does it mean blind ending umbilical vein, or will it be a cavernous anastomosis with hepatic veins, or it includes IHPSS also? Guha, that's what we were discussing. In our protocol. Once we don't see the DV, then we map the portal vein as usual. And if no other shunt is seen, then we put it as simple ADV. After which gestation age Popper system mapping needs to be done in DV abnormalities. You can start seeing, it is only technical limitation. So you can start seeing the main portal veins as early as maybe 16 or 14. If the baby doesn't keep jumping, the only restriction would be the baby keeps jumping by the time you put the spectral waveform. So try even earlier, but don't put too much color in very early fetuses. All right. Thank you all, and thank you, Narmada, for excellent presentation. Even though you are not well, we know great effort. Keep it up. Bye all.